Hi there, my name is Vic Bear. I'm an ENT surgeon. If you've been following this channel for some time, you may know now the signs and symptoms of someone with obstructive sleep apnea or sleep breathing disorder, like snoring, waking up feeling tired, waking up with a headache, sweating, feeling hot at night, waking up to go for a wee, feeling tired during the day, gaining weight, all those sorts of things. But there are some people out there who then go, right, I must have a sleep breathing disorder. I better go and get checked out and look at my sleep study. Sometimes that sleep study comes back as completely normal, or they're told it's completely normal. And then you think, no, I can't be, I can't be wrong. There's something going on here that is actually, they haven't picked up on the sleep study. And it can be true that you have no problem with your sleep at all. It's another problem altogether. I'm not going to go through all the things that cause tiredness, headaches, and things like that. However, there are lots of things, and I'm going to pick out 5 things today. 5 things on your sleep study that are often missed. And if you could look at your sleep study, you might be able to pick it up yourself. So the first is positional obstructive sleep apnea, which means that you sleep much, much worse when you're lying on your back. But when you're lying on your side, you're not too bad at all. So when you look at someone's sleep apnea report, they go, your AHI, that's the number of times you stop breathing every hour on average. Your AHI is less than 5. That's within the normal limits. You don't have sleep problems, go away. But if you look closely, really look closely at the sleep study and ask for the result of your AHI when you're lying on your back compared to when you're lying on your side. For example, lying on your back may be 20 or something like that. So in the moderate range of obstructive sleep apnea. But when you're lying on your side, you're 2 or something. And because you spend 80% or something lying on your side the whole night, on the night of your sleep study, the average of those 2 ends up being less than 5. And so the doctor might say, oh, your AHI is less than 5, it's 4.9 or whatever it is. Therefore, you don't have sleep apnea, don't worry, it's very mild. But it may be on that particular night you somehow fluked it and slept great, slept on your side most of the night, and therefore didn't really pick up the fact that you have supine obstructive sleep apnea. You're really, really bad sleeping on your back. And if you knew this, and maybe most of the nights you're sleeping on your back, and just happened to be that night you were sleeping on your side more than often than not, just because of that one night, you're sort of labeled as not having obstructive sleep apnea, whereas you have sleep apnea when lying on your back. So make sure you look at that number, the supine AHI and the non-supine AHI. The average is almost pointless because if it's peaking and going up and down like that, you're ended up just about here or even down here. There's no real point. Another thing that works similar to that is REM, obstructive sleep apnea. REM obstructive sleep apnea means rapid eye movement. That means when you dream, only when you dream, do you get obstructive sleep apnea. That's quite interesting because I've noticed in my patients at least, when people are getting sleep apnea only when they dream, it ruins their dreams. And you really need dreams to remember new things, to avoid brain fog during the day, to feel productive at work, all those sorts of things. If you're not particularly tired, but you're just rubbish at your job or rubbish remembering numbers or the things that you used to be able to do before you had these sleep problems, then maybe you have REM associated sleep apnea. So look at the supine AHI, look at the non-supine AHI, and also look at the REM AHI. Because the REM AHI will tell you in that sort of 10% or 15, 20% of the night when you're dreaming, how bad your sleep apnea was during that particular phase. It might be that you're just ruining all your dream sleep and the rest of your sleep is fine. And so the average stays below the 5, whatever. I don't know where they picked up 5 from, but 5 is the magic number, apparently, according to the American Academy. And so if you're less than 5, but actually during every one of your dreams, you're terrible, it might be that you have dream sleep obstructive sleep apnea. And just a bit of background, the reason why people get dream sleep apnea is because our bodies have a little bit of tone, and muscles have a bit of tone. So when you're lying on your back particularly, which is why the positional sleep apnea happens. When you're lying on your back, normally, not all the time, normally it's either your tonsils or your tongue fall back and block your breathing. And when they block your breathing, you have to take a breath and you roll over to your side so you can breathe again because the tongue rolls out of the way. And you've seen stuff about my pillow that I invented that gets you to sleep in the recovery position. The recovery position means that you're sleeping with your tongue into the pillow, or in the hole, in the letterbox in the pillow, so your tongue can roll out of the way. But you don't need my pillow. You can just get a positional device, anything to get you to sleep in the recovery position to let your tongue roll forward out of the way. The same thing we think happens with REM, obstructive sleep apnea. When you dream, our bodies don't want to act out all these dreams. So all the muscles go very flaccid and limp. And so the tongue, you might be holding it back so you don't have problems when you're lying on your back, but only when you dream when you're lying on your back. Because all the tone in your muscles disappears when you dream because you don't want to act out your dreams, the tongue really does fall back, block your breathing, and therefore you have to roll over and you disturb all of your dreams. If you don't get proper dreams, you get all the problems with loss of concentration, brain fog, all those memory problems and things like that. So those two things, positional and REM associated sleep apnea. So look at supine AHI, non-supine AHI, and REM AHI. They're really important. So make sure you get those numbers, not just the average. You want all of those numbers as well. Now, another thing you may have is upper airway resistance syndrome. Now, I don't particularly like that term because it's almost like a catch-all for lots of different syndromes. And the problem is we haven't defined upper airway resistance syndrome yet. We know there are lots of people outside of the AHI sort of group with greater than 5 have problems. And we just lump them under this term, upper airway resistance syndrome. And I'll explain to you what I think these syndromes are, and I'll break them up for you. Although this is going to get a bit complicated, but people who watch this video or follow my channel will know more about this than most people. So the first thing to know is that many people define upper airway resistance syndrome based on something called the RDI, the Respiratory Distress Index. And what that is the AHI, that's the apneas and hypopneas. And apnea is when you completely stop breathing, you can't breathe at all, and then you have to take a breath because your oxygen levels drop a little bit, and other little criteria like that. That's really bad. Your airway blocks completely. That's an apnea. And then there's a hypopnea, which is almost the same, just not quite as bad. And we get upset about the definition about that still. But when you add these two together and divide them by the number of hours you slept, that's called the AHI, the apnea hypopnea index. Now, there's another thing called RERAs, which isn't an apnea, isn't a hypopnea, but it's still a respiratory event that seems to wake the patient up, but doesn't really meet the criteria of apnea or hypopnea. And so they're being called RERAs. So an AHI is simply that, apneas, hypopneas, but no RERAs. A respiratory distress index, RDI, is apneas, hypopneas, including the RERAs. So all those little events, those respiratory events that seem to wake up the patient, not to the point where you know that you've been woken up, but enough to arouse the brain so you take a breath and all those sorts of things. So we can see on the sleep study that you've been woken up by a respiratory problem, and until that moment, we haven't counted it as a respiratory problem. It's an unusual situation. So there are lots of these in some people where they have a completely normal apneas, very normal hypopneas, but loads and loads of RERAs. So they're based on arousals typically. They wake you up and there's a respiratory event. So lots of people say upper airway resistance syndrome is basically the RDI. And if you have a high RDI but a normal AHI, therefore you have upper airway resistance syndrome. I'm not sure I agree. I think that's a different syndrome altogether. I mean, I would, if I saw someone with a high RDI, I'd call it upper airway resistance syndrome in the absence of a proper term for it. And I still think it's important. But I think it's a different syndrome to some of the other things I'll talk about right now. So yes, there is something going on. And it's not just really, really mild sleep apnea, because under 5, you're in the normal territory. What is it, minus AHI? It's not like that at all. You can have an AHI of 2 or 1, but an RDI of 25. So I think it's a separate syndrome. It's not just on the same scale as the AHI scale. So I don't want any confusion about that. So I hope you understand that side of it. And at the moment, it's lumped under this upper air resistance syndrome bracket. Now, there is another way to look at it. There's something called the flow limitation, which some people, including me, use as a way of picking up people with obstructive sleep apnea and upper air resistance syndrome. Flow limitation is the amount of air going in and out through typically your nose, because there's these little tubes that go in your nose at night during a sleep study, and it monitors the airflow coming through. So typically, you need to be a nasal breather for that to happen. If you're a mouth breather, your flow limitation index will be very high because there's limitation of the flow. And so it doesn't work well with people with a blocked nose. These sleep respiratory consultants who made these sleep studies assume that everyone has a great nose. Actually, most people with obstructive sleep apnea, upper air resistance syndrome, all these other breathing disorders have terrible noses because you have to have multiple problems going on with your airway for you to start having these problems in the first place. But that's beside the point. Say someone has fixed your nose and we've checked your nose and there's a clear passage right to the end and you can see the palate moving when you look at the front of your nose like this. And there's definitely not a nose problem. You can pick up upper air resistance syndrome this way. So these are the young, thin, tall men who, when you look at their flow limitation, even though their nose is perfectly normal, you see that it often seems to get worse, typically when you're lying on your back. Or they may have a very large tongue for their throat. Sometimes we blame it on dentists in the 80s and 90s removing lots and lots of teeth, and so your jaw doesn't grow as big as it should do. And there's small jaw, big tongue syndrome. I don't know what people would call it, but there's not enough room for your tongue inside your mouth. So there's that aspect of it as well. So a lot of these people who are young, thin men, very depressed because they can't get on with their life, young man sort of neurochemistry is built on conquering the world and making your mark and all that sort of stuff and finding a mate. And, that's how our brains are wired. And to be so tired that you can't do anything, it is quite depressing. And so trying to figure out what's going on with these people is quite difficult. But often it's the flow limitation that picks it up. Now, if you're not sure whether it's a blocked nose or your tongue falling back on the flow limitation, have a look at your sleep study and ask for the flow limitation, again, supine and non-supine. And if you've got REM, that would be great as well. Because if you can show that there's a difference between lying on your back and lying on your side, that suggests that it's a tongue-based blockage causing the upper air resistance syndrome. Now, if it's blocked all the time, that could mean you have a very blocked nose because your nose is like this the whole night, and therefore it's not picking up any flow at all. And that may be the reason why it's looking like there's a problem with upper air resistance syndrome, but really you've just got a blocked nose, looking at the flow limitation only. Hopefully that's not too complicated. I'm throwing in loads of information. Maybe you don't need to know this. Now, the next thing is what I personally think is upper air resistance syndrome, which is if we manage to delineate all these little syndromes, this is the one I would stick to upper air resistance syndrome, which is all about respiratory effort. Although there's no definition, the best way to pick up upper air resistance syndrome is using an oesophageal manometry, which is basically a tube, a pressure sensor that goes into your nose, down the back of your throat, into your esophagus, into your gullet, the tube that goes down to your stomach. And you leave it there all night. It sits in the middle of your chest here. And the idea is that it senses the pressure as you take a deep breath in. Now, when we sleep at night, we take shallow breaths. We don't need to breathe that hard. We're not running around. We're resting. And so we take shallow breaths, and therefore the little manometry, the little sensor in there doesn't pick up an awful lot. But if you're breathing really hard, trying to get air in and out because you've got an obstruction up here, not obstruction, but a resistance. You're trying to breathe through a narrow airway, upper airway resistance, not blockage, resistance syndrome. Then this sensor picks it up. It picks up you trying to work so hard to get air in and out of your lungs. You're not losing any oxygen. You're not gaining any carbon dioxide as such, but you're really, really struggling. So that's what I think, that it doesn't have anything to do with arousals. It hasn't got nothing to do with flow as such. It's really to do with how much effort you're using to breathe. So that's subtly different from the other two I've just talked about, the RDI, which is all about arousals. And it's not about the flow, because you could have huge amounts of flow going through, but you're just having to work so hard to get that flow. Not everyone can have a esophageal manometry because, at least 20% of people can't tolerate it and just gag it out and pull it out afterwards. So it's not very nice having this in. I tend to use the RIP phase. So on good sleep studies, you'll have a band that goes across here, like a slightly elastic band, and another one across your tummy. And the idea is that it monitors how much you're expanding your lungs, almost the same as manometry, but not quite. How much you're expanding your lungs, and in particular, you see the difference between your stomach and your chest. We like to see a normal, you breathe in like this, and your stomach opens up as well. But sometimes you get it the wrong way round, and it's because your body's desperately trying to breathe, and you sort of go like this. I can't do it, but it goes out of sync. The lungs and the stomach go out of sync, and therefore you can pick that up as well. So paradoxical breathing, I think, is useful. The RIP phase is very useful to look for respiratory effort. You could look at the respiratory rate as well. That's quite useful. But I would be it's quite hard to look at these things. Fortunately, with the sleep studies I use, you can get a number out of the RIP phase, but typically it's a trace that you're looking for. So in this umbrella term of upper air resistance syndrome, you've got the arousals or the RERAs making up the RDI. You've got the flow or the flow limitation index, which is the airflow through your nose, which can be annoyed by the blocked nose problem. We have respiratory effort as well, which is the RIP phase, respiratory rate, paradoxical breathing, all those sorts of things. Now, another way, if I'm convinced that someone has upper air resistance syndrome, even though the sleep study looks normal, you can just listen to them sleep. Sometimes they go, I must have sleep disordered breathing, because when people hear me, they think I'm dying. And when you listen to someone breathing away, so sort of doing this all night, even though it's not showing up in the sleep study, there's something going on there. And sometimes it's purely because they've got a really blocked nose, and they're not blocked during the day when they're standing up and all the fluid drains from their face. But when they're lying down, their turbinates swell up or something like that, or some other problem happens in their airway that everything swells up and blocks your nose. And it could be simply that you don't have sleep disordered breathing, you've got a blocked nose. I mean, officially, I guess, if it's interfering with your sleep, then yes, it is sleep disordered breathing. But fixing a blocked nose is so easy for us. You can have a spray or something like that, and that normally sorts it out. I think another section of this upper air resistance syndrome thing might be a rising carbon dioxide level. Now, there aren't many places that do that, and trying to get carbon dioxide levels rather than oxygen level drop, carbon dioxide levels rising, because you can't blow off the oxygen. That could be a thing as well. It's getting a bit complicated, but those are all the umbrella terms for upper airway resistance syndrome. So I've talked about a few things now. I've talked about supine obstructive sleep apnea, REM associated obstructive sleep apnea, having a blocked nose, which I just mentioned now. You could also have upper airway resistance syndrome. And I guess the other thing that could be on a sleep study, but it got missed, was all the weird things that are going on with obstructive, with your sleep. So it's a bit like other parasomnias, the inability to go from one stage of sleep, so stage 2 sleep, down to stage 3 sleep, deep sleep, or the inability to cycle through your normal sleep cycle. There are loads of different diseases out there, different syndromes out there, which mean that you can't get good night's sleep. It's not a sleep breathing problem, but actually a sleep problem. And it may be that your sleep study is set up to look for sleep apnea, which is the most common of sleep problems. But it may be that you have a completely different problem that's very rare. So this might affect those people who are, okay, so I feel dreadful. I've been given a CPAP or a mandibular advancement device. My numbers look great, but I still feel dreadful. And it may be that you've got sleep apnea as well as something else. So I told you to look at your supine, REM, AHI. I've told you to look at paradoxical breathing, RIP phase, and all those things. But it may not be on your sleep study. Maybe you've not had a sleep study that's good enough to pick up these problems. Maybe you need to turn up and wear your mandibular advancement device or wear your CPAP and then have a full-blown in-house, in-hospital polysomnography with all the sensors on your brain and all those sorts of things to try and work out what stage of sleep you're in and try and figure out why you're having these problems. And that might help you figure out what your problem is, because it's not as simple as often is depicted by doctors and by the general public as well in YouTube videos. Sometimes it's really, really difficult. And trying to figure this out, sometimes it's one step at a time. Okay, we can see sleep apnea. Let's fix that. Oh, you're still feeling bad. Let's do the sleep study again. And this time wear your CPAP mask, because that seems to be working. But there must be another reason why you're so tired. And then you can work backwards from there. I hope that helps. I'm going to go into the next video now. And I should have really mentioned about arousal thresholds and things like that, but actually it was getting too complicated. I hope you understood all of this. Do take care. I'll see you in the next video. Bye-bye.